So we are going to talk about Hangman's fractures, and for those of you that were here yesterday, we had a nice, interesting case of an atypical, unstable Hangman's fracture. We'll talk about that specific type in just a moment. But these are classified. Effendi describes sort of the first and most utilized classification systems of Hangman fractures in the 1980s. Hangman's fracture is a fracture through the isthmus or the pars interarticularis of C2. So between the inferior or the inferior and superior articular processes of C2, because C2 is an unusual vertebra, there's a large superior articular process of C2 that's very anterior. There's a very large area of the isthmus or pars interarticularis of C2, and that's where these fractures occur. Of all C2 fractures, they comprise about 25%, not nearly as common as odontoid fractures. There's a fairly high associated spinal injury, so a contiguous or non-contiguous level in about 30%. With a very low incidence of neurologic deficits, as we talked about last night, because these are typically canal expanding lesions. They actually expand the spinal canal if they're truly through the isthmus or pars interarticularis, so there's a low incidence of neurologic deficits. So in Effendi's classification, it's pretty straightforward. Type 1 injuries, less than 3 millimeters of displacement, no angulation, so basically non-displaced fractures. Type 2 are greater than 3 millimeters of displacement with some C2, C3 instability, and we'll talk about that in just a moment. And then type 3 fractures are facet dislocations at C2, C3, which are uncommon but are significant to know and understand. So the vast majority of Hangman's fractures are these type 1. 70% have basically minimally displaced, less than 3 millimeters of displacement, and typically they can all be treated in a cervical collar, no halos. Most of them do extremely well non-operatively in a collar. Type 2 Hangman's fractures, again, greater than 3 millimeters of displacement, and there's variable disruption of the C2, C3, basically disc with annulus, ALL, PLL, and ligament flavum injury of some type. Type 3 Hangman's fractures include a facet dislocation at C2, C3, and all of these require surgical reduction. As we talked a minute ago about these fractures, basically this is a facet fracture. So rather than being able to distract and reduce this closed, what happens is you end up distracting across the fracture itself, and these become essentially impossible to reduce in a closed fashion. Starr and Eismont described an atypical Hangman's fracture. As you see here, see this fracture that actually is through the posterior vertebral body, and this was the fracture that I showed last night. These atypical Hangman's fractures are very interesting, and as you see here, the fracture is not through the pars interarticularis, but it includes the posterior vertebral body of C2, and so these are not canal expanding fractures. And Starr and Eismont showed quite clearly this is a different variety and a very, very concerning type, an atypical type of a Hangman's fracture because of the increased incidence of spinal cord injury, and as you saw last night in that case, a very severe and potentially catastrophic spinal cord injury. A subtype, type 2A, Hangman's fractures, has less displacement but more angulation at C2, C3, and this was basically described because of the concern about traction, that actually placing these patients in traction can actually over-distract this injury and cause a significant concern. So again, very difficult to treat non-operatively in traction. So the question usually is not about type 1 Hangman's fractures that almost all heal fine in a collar, but what about type 2 Hangman's fractures? And should these be treated, or should they be placed in a halo? And I debated a very famous spine surgeon a number of years ago now, is either at CSRS or the Academy, who advocated for halo treatment. Jens is laughing. So Dr. Vaccaro published a very well-known article on treating these type 2 Hangman's fractures, these displaced Hangman fractures in a halo, and said that they actually did quite well. But when you actually look at this series, they are hard to treat. They are very, very hard to treat. Actually, he described 27 type 2 Hangman's fractures. 21 went on to union, so he actually had a 22% failure rate, and a number of them had to come back to the operating room or back into the hospital to be placed in traction again. And so they were in the hospital for an extended period of time. So these are not easy to treat in a halo. These are complicated to treat in a halo. And who likes to wear a halo, right? Look at this poor guy or in a Minerva vest, right? So these are hard to treat. And as in Vaquero's article, many of them required a long hospitalization, even despite being treated non-operatively. Halo complications, I can't wait for Jens's discussion later tonight on the horribles of halo treatment, but especially in older patients. I mean, there are significant complications that can occur, and I mean, we kill older patients by putting them in halos. And this major complication, this is a study very clearly showing the complication rate in halos and mortality rate in elderly patients who are treated for odontoid fractures in a halo. So treating patients in halo is a difficult issue. Because of that, there are others who have recommended surgical treatment for type 2 and type 3 Hangman's fractures, and this is one of the earlier ones. Again, surgical treatment has a very, very high incidence of success without having to place patients in halos post-operatively, especially those patients that have significant injury of the C2, C3 disc space, which makes these very, very unstable. A systematic review was done a number of years ago looking at Hangman's fractures, and surgical stabilization was recommended in type 2 Hangman's fractures with significant dislocation, although, again, because the vast majority of Hangman's fractures are minimally displaced. When you look overall at the treatment of Hangman's fractures, the vast majority, 2/3 or 3/4, are treated non-operatively, with a very, very small percentage being treated operatively. But if you look at the fractures type 1, type 2, type 3, which is a good classification system. As you go up on the classification system, there's less and less and less success in treating these patients non-operatively. Again, that's what's a good classification system, is that you can make a good prognosis, and it can define our treatment. Kohler actually was one of the first that said, listen, it's crazy to place these patients in halos. They're miserable, they don't like being in a halo, and all these type 2 Hangman's fractures should be treated operatively. And what he recommended is a construct that I showed you yesterday, where a screw is placed across the fracture site at C2 and then connected to a lateral mass screw in C3. So there are a number of surgical treatments, surgical constructs. One is an anterior interbody fusion at C2, C3. We'll talk about that in just a moment. A second is a Judet screw. Actually, Judet described just fixing the fracture itself, one of the few fractures that we as spine surgeons can treat. Type 2 odontoid fracture is another one. And then a transperpendicular C2 screw with a lateral mass screw in C3, or various constructs that may include C1 or the occiput and farther down. We talked about that yesterday. Maybe because of other issues of canal narrowing, we may need to go above or below in order to adequately treat these. So here's a case that was treated, a type 2 Hangman's fracture treated with an anterior discectomy infusion that actually fused quite nicely. There are some technical issues, though, in treating these anteriorly, and one of the most common, as we see in a number of these studies, is dysphagia. As we all know, the higher up we get to expose the cervical spine anteriorly, the more incidence of dysphagia and swallowing issues, especially in older patients. This can be a significant problem. So dysphasias and hypoglossal nerve injuries need to be considered. This is actually a case of mine, not of a Hangman's fracture, but showing the significant difficulty with placing screws up at C2, as you see here. Couldn't put a screw in the upper part of this plate because of the mandible being right here. So these can be very difficult to treat anteriorly. And so because of that, there have been a number of case reports treating them posteriorly. And this is a nice little thing from our buddy Benny Jeanneret in St. Gallen, showing the most critical issue, however, if you treat these posteriorly, is worrying about the vertebral artery. And we had an extensive discussion last night in the case that I showed you about the vertebral artery and the anatomy of the vertebral artery. You need to understand the anatomy of the vertebral artery. For you fellows, understanding where the vertebral artery groove is and where your screw will be in relation to the vertebral artery groove, and making sure that you keep your screw away from the inferior aspect and the lateral aspect of the isthmus, because that's where the vertebral artery is. So anyway, again, the concern with treating these posteriorly with screws across the isthmus is potential vertebral artery injury. There have been a number of studies looking at screws placed transpedicular in C2 with fairly high rates of misplacement of the screws, 21%. I think that is fairly high. There's a number of studies looking at navigation. We had a nice discussion about robots and navigation. Maybe they can make us better. Maybe they don't make us better. This is a very interesting review or case report of Judet screws, but again, significant issue with blood loss. He clearly got into the vertebral artery with a liter of blood loss in a matter of minutes. So biomechanically, when you look biomechanically at these constructs, anterior versus posterior, actually what's quite interesting is that Judet screws, or screws just across the isthmic fracture itself, are very inefficient. They are not very strong. And posterior C2, C3 construct is much, much more stable than anterior fixation at C2, C3. We'll talk about it in the other talk I have on anterior fixation. Again, we all know that anterior constructs are not nearly as strong as posterior constructs, and even at C2, C3 for these Hangman's fractures, that's clearly shown. So a number of these case reports now showing the construct that I showed you yesterday with screws across the fracture hooked up to a lateral mass screw in C3 showing very, very nice results. So the question about displaced Hangman's fractures, should they be treated with a halo? I think that's becoming less and less common now because of the difficulty in keeping them reduced, and also the issue of halo treatment. And whether they be treated anteriorly or posteriorly, I think my preference is to treat these posteriorly with the construct that I showed you last night. Thank you so much for your time and attention.
So one of the big questions that I always had about type 2, type 2A injuries was the amount of discovertebral injuries. If the plain x-rays that you have initially don't give you a hint, or the CT, how much do you rely on an MRI? And is there a role for traction, again, to try to study the exact mechanisms of instability of the type 2/2A injury, which I still, if I gather that correctly from you, you agree with is somewhat of importance?
Yeah. So to answer that quickly, I think MRI gives us better information and is less dangerous than actually putting traction on. I mean, I think that the 2A classification came about because of the significant issues that were found putting these patients in traction. Putting traction on and finding out, oh my gosh, we distracted too much across the segment, and showing how unstable these 2A fractures are. And I think that the reason they are so unstable is the discoligamentous injury that has occurred, the significant disruption of the C2, C3 disc space that makes them grossly unstable. Yes?
Dan.
So, given that the vast majority of Hangman's fractures are neurologically innocuous, right? I mean, they're not neurologically dangerous injuries by and large. There's lots of room up there, and most of them can expand the canal.
Right. The vast majority, except the one we saw last night.
Well, yeah, but in the vast majority, right? And in the sense that I don't understand my experience has been that most of the time, even the displaced ones go on to spontaneous fusion at C2-3. Like, that's the natural history.
Treated how?
Anyway.
Even in the collar?
Yeah, right.
Okay.
That's how I treat, except for type 3s, right? I treat all Hangman's fractures.
With facet dislocations.
Right, because you obviously can't treat that non-operatively. But every other Hangman's fracture, I just treat them in a collar.
So you don't care how bad the
Well,
X-ray looks?
that's my question, right? So what, are we treating an X-ray, or is there some degree of deformity in the upper cervical spine that's going to lead to chronic pain down the road, as opposed to buggering up the C2 nerve root while you're doing a posterior fixation? I mean, that's exactly it. So everybody wants to say, let's compare halo to surgery, but why not compare collar to surgery and let your endpoint be some kind of clinical outcome, not, oh, the radiograph doesn't look as nice as, it makes me nervous as the doc, as opposed to the patient could give a crap.
Yeah, so let me address that, because all we have is our literature, right? What we hang our hat on is our literature. You should do that study that you just said. The problem is that the vast majority of the studies don't have type 2 fractures treated in a collar. They're treated in a halo. And that's what Alex's, his sort of seminal study on type 2 Hangman's fractures. They're all treated in halos, not in a collar.
Josh. Oh, so Andrew first? Yeah.
Yeah, just a quick question on the technique for those Judet screws. Is that a lag screw that you put into the anterior vertebral body at C2 and then pull the vertebral body back?
Yep, so if it's a true Judet screw, and what he described is just fixing across the fracture, not extending this to C3. So he must have been treating fractures that did not have significant C2, C3 disruption. So it's a true lag screw. Yes, you want to fixate into the body fragment and lag across the fracture. It's a beautiful. It's actually beautiful. I love it. The problem is biomechanically, it's not very strong. In fact, it's not even nearly as strong as an anterior C2, C3 discectomy infusion.
And Josh?
I mean, biomechanically, I understand the logic between a C2, C3 anterior, right? I mean, the tension band, all that stuff. But if you're putting the screws in C2 across the fracture line, wouldn't you want to connect it up to C1 because of the shape of the fracture where it's attached to, just to get more of a tension band? Because a failure of the tension band would be more between C1 and C2.
Most of these injuries are injuries of C2, C3, not C1, C2.
No, but the disc, I mean, I agree with the disc, but I just think, maybe I need to explain it, but I mean, if the fracture is taking the dents anteriorly, it's attached to the posterior, it takes a C1, C2 dents anteriorly, right?
Well, most of these are not injuries of C1, C2. They're not
No,
TAL
right, but the
injuries.
C1 and C2 are attached together, right?
Okay.
So the C1 with the anterior with the dents through the pars will start traveling forward, and the C3 in the posterior part of C2 will stay in the back, right?
Yes.
So in order to reconstruct the tension band, wouldn't you need to go up to C1?
I think as
to hold
long as
it
you
into
get
place?
good fixation to the body of C2, assuming that you get good fixation into the body, you don't need to do that. I mean, obviously, if you don't get good fixation, right, then you do need to you need to go above, and that's where some of these constructs did include C1. Clearly, they weren't able to. I mean, clearly, if you're not able to get into the body of C2, you're going to have to go to 1. Or actually, some people historically went to the occiput. These were occipital cervical fusions treated posterior, which I totally agree is not nearly as optimal as treated in a halo. But with our techniques now, I mean, what's a C2, C3 fusion? I mean, the really minimal morbidity.
And maybe you can show us how a simulated Judet screw would be placed, a proper pedicle screw in C2.
Yeah.
Honest answer, I mean, obviously Josh comes from a 2-robot OR environment now. Do you use image guidance robots now in your OR for upper C-spine fixation?
So I don't, except for the case I showed you yesterday.
Okay.
I did for that.
Yep.
Because I was worried about the vertebral artery. I wanted to make sure I was absolutely far away from it. But I use navigation for every instrumented thoracic lumbar case that I do, and I've been using it for 20 years. I mean, we're really involved in sort of the development of navigation, but I don't navigate in the cervical spine, mainly because of the difficulty of the instability of the cervical spine and where you put your reference frame. It's just not accurate. It's not optimal. In the old days, when we did transarticular C1, C2 screws, Magro, or anterior odontoid fixation, I did navigate them so I could get rid of using 2 C-arms. That way I would only use 1 C-arm. Having that AP C-arm and getting that out of the way is a huge advantage, and that's why I would navigate those. But now I don't even do that anymore.
Great. And you will have a chance to see this artist and Dr. Daly work together on posterior C1, C2 fixation. Ed?
Yeah, just curious, interoperably, what are the steps you take to achieve a great reduction in these fractures?
A great reduction?
Not
Yes,
a good
sir.
reduction, a great reduction.
A great reduction.
Perfect reduction.
I think it all depends on where, what type of fracture it is. I mean, I would go through what we just did, putting Garden Wells tongs on. If there is significant instability, to try to get them reduced as well as I can. Clearly, if there's if it's a type 3 where the facets are dislocated, that's not going to do anything. You're going to have to take them to the operating room in order to do that. But I think it's work. Is it putting a roll under their shoulders? Is it extending their head? Is it But I want to do that with them awake and alert as much as possible, get it reduced as best I can actually before putting them to sleep.
Great. Super lecture. Thank you so much for
Thank
your
you.
insights.
Thank you very much.